I wonder whether you know what these are and from where they might have come. Is anybody prepared to guess? What do you think those are? Anybody over here? What do you think?
Piece of chalk.
Piece of chalk. In fact, you're not far wrong. They are crystals of calcium oxalate. Now, chalk is calcium carbonate. Those were taken from a bladder of an individual 20 years ago, and he's still alive. It wouldn't surprise you, I'm sure, if I told you that these are also crystals formed in the bladder of another patient. He too is still alive. And this is rich in magnesium and phosphate. Crystals like that form in the body, they form in the bladder, they form in the kidney. You can live on one kidney, as this gentleman did, after this particular kidney was removed, because you can see that was diseased. It had two quite huge stones of calcium oxalate. Crystals like that form in the body. If you take these crystals out, and these days you can take them out without incision, we'll tell you how that's done a little later, look at them under a scanning electron microscope, magnification of about 500, they've been bashed a bit to make them smaller. That's what they look like. Now, if we zoom in on this, increase the magnification, here's a little boulder, you might say. It could have come from the Highlands of Scotland, of calcium oxalate. That's just one of the crystals that grows in the body. There's another crystal that grows in the body, which I'm going to show you next, and that's cholesterol. Cholesterol forms in the arteries of the blood. Here it is. Progressively increasing magnification. It's like the slate quarries of North Wales. You see them? It's now at about 5 to 10,000 magnification. Very beautiful looking things, but they can be very awkward. If you look at them under an optical microscope, as I'm going to test here, yes, there they are. It's a polarizing microscope. As I move the stage around, you'll see that there's really quite a pretty sight there. Those are the crystals of cholesterol that block up the blood vessels. Now, in this lecture, we're going to describe how the study of crystals and lasers helps us to understand the way in which the human body works, and also how to overcome diseases. Let me begin with a very remarkable and puzzling fact. There's so much calcium in our blood, so much phosphate in our blood, that we would expect, if simple chemistry were to hold, we would expect quite massive crystals of calcium phosphate, rather like this mineral of apatite, not quite that big, of course, to form inside our bodies. Calcium phosphate. It doesn't happen, mercifully, otherwise we would be blocked up. We'd be like stalactites. Now, the interesting thing is that in the bladder also, there's so much calcium, so much oxalate, even in the normal human being, you'd expect large crystals of calcium oxalate to form. Doesn't happen. Only under certain conditions. When you're unhealthy do they happen. Do you remember in the first lecture, I prepared a saturated solution. I dissolved up alum, as much as could go into that tap water. And I made a concentrated, really saturated solution. And then I took a small crystal of this alum at the end of a little piece of cotton, and I immersed it. Over the last few days, that crystal has been growing inside that saturated solution. And lo and behold, here we have it. In the period of time that's elapsed, we've got a very nice looking crystal. I'll take it out for you, just for you to see it. And if you look carefully, at the bottom there, there's a harvest of smaller crystals. Now that's well understood chemistry on the laboratory scale. What I'm telling you is that in the human body, we would expect crystallization to occur quite rapidly on this scale, and it doesn't. Now, we really have to understand that. And I need a volunteer at this stage. Is anybody prepared to come and help me? How about you? You come along. What's your name? I beg your pardon? Zoe. Come here, Zoe. I've got an interesting little experiment for you to do. Now, Bryson's going to take the top off that saturated solution. It's very saturated. I want you to handle these tweezers. Just get hold of these tweezers. There we are, look. I want you to pick up one of those crystals. Let me tell you what I want you to do. Pick it up with those tweezers. Take it up here to the middle and drop it. Drop the crystal, that is, not the tweezers, okay? Good, there you are. Good. Very fine. Up you go. Drop it. Right. Now, I want you to watch. You come along here now. You bend a little. See what's happening. What's happening there? Tell us what's happening. It's getting bigger, isn't it? It's getting very much bigger. Well, look, let that grow. Let that grow. In the meantime, come over here now. I want you to pour this solution into that. Go ahead. Just pick it up and pour it into there. And pour it right in. There you are. My goodness. Good for you. Put it down. You've prepared crystalline lead iodide just by putting iodide into a lead solution. That happens. We expected it to happen. We expect things like that to happen in the body, but it doesn't. Look what's happened here now. See how much further that's gone? See, if we wait, that will go right through down to the bottom. It forms one solid mass of crystal. Thank you very much, Zoe. You've been very helpful. Now, what I'm saying, therefore, is this is a dramatic illustration of what happens in laboratory chemistry. We would expect, on that basis, to see much more crystallization in the body, and it doesn't happen. Well, sometimes, to be correct, crystallization happens on a slow scale, and it should in the formation of our bones or teeth. That's reasonably well understood. I'll get onto that later. We lay down in gradual fashion, not calcium phosphate, but to be precise, it's calcium hydroxyphosphate. It's called hydroxyapatite. More of that later. But you know, there are some people who suffer from a problem, and this has been so for at least 7,000 years. We know this from ancient Egyptian mummies. They suffer from a problem where too many crystals come out and they can't do very much about it. Now, I want you to help me find out what it is that these people have in common. Look at this gallery of famous people here. We've got John Wesley on the left. We've got Casanova. What do they have in common? Benjamin Franklin, Sir Isaac Newton, Queen Anne, Charles Darwin, and I could put Christopher Columbus and W.S. Gilbert and many more. Now, what do you think these have in common? What did they have in common?
They're all dead.
Well, that's a very good answer. They are all dead. That's very good. If I were to tell you, though, that there are at least 20 people in this audience, and by the time all you children are 60 years of age, 10% of you will also have the same disease, whether you're dead or alive, right? That's not the answer I was looking for. So let me give you a clue. I'll give you a clue. Underneath here, we have a very important person, a guest that we've invited along. Here he is. Now, what is this man suffering from? Does anybody know? I recognize you from an earlier lecture. What is he suffering from? No, well, that's a good idea. He hasn't broken a leg, but something pretty troublesome occurs down at the extremity there in his foot. What he's suffering from is a complaint that I will talk about. It's called gout. Now, let me tell you what gout is. On the next slide, if you look at this, the X-ray photograph here tells us that this bone and that bone over there in the toes are obviously suffering badly from overgrowth. There's too much growth there. What's happened is that crystals, a little bit of cholesterol, a little bit of calcium phosphate, and a lot of sodium urate is formed there. Now we have to try and understand that. That's the condition of gout. It's very painful. It's thought to be due to high living, and hence the reason why we've given this wonderful atmosphere to Father Christmas. He benefited from high living and paid the price. Now, what I want to, therefore, try and piece together, if you look at the next slide now, I want to try and explain to you how it is we can understand the laying down of hydroxyapatite in bone, how that happens. And then next, I want to explain the absence of large-scale crystal growth in the bladder and in the kidney and elsewhere. And lastly, I want to say a few words about gout. Now, bone is a remarkably important material. We don't have to emphasize that too much. In every bone, there's long rope-like proteins which are called collagen. They're triply stranded and they're right-handed thread, like this. And my body and your body, the DNA that we have, decides precisely what kind of collagen you and I are going to have. And along the backbone of that collagen, it lays down groups of atoms. It lays them down periodically. That's a genetically controlled factor. So that these groups can then serve as very nice receptacles for calcium. That's a charged calcium atom. Charged calcium atom. That's how the nature has worked out how to lay down bone. Let me give you a cleaner illustration of that. Here now are 2 strands of collagen, and here are 4 receptacles. Now, calcium phosphate, of which bone is made, or hydroxyapatite, can lay down perfectly. It fits, you see. That's the point about these receptacles. We can get them to fit perfectly in a nice, settled, nestled fashion. And on it goes. And you have a very strong bone, not only because you've got a good, strong crystal there, but also because you've got these fibers there. You know, you can strengthen glass. Fiberglass is strengthened. Concrete is strengthened by having rods of steel in them. It's exactly what happens in bone. As you grow older, or sometimes even at birth, there are problems with one's bones because they're brittle. And that's partly genetic. It's partly genetic. But also it happens because the collagen isn't quite doing its job. It's necessary, therefore, to think of bone replacements. You know, all over the world, every year, there are 500,000, 500,000 people who benefit from hip replacements using stainless steel, a technique that was developed in this country 25 years ago. Very important. It's relieved immense hardship and pain, and it's a wonderful invention. However, these days, there are prospects of even better progress in the question of building man-made bone. Here I have a lump of coral, calcium carbonate, marble, which is what you said earlier. Calcium carbonate. Bone is essentially calcium phosphate. Very clever work now going on in Queen Mary College in London and also in Pennsylvania State University in the United States, where, especially in that latter center, they've converted coral to bone, to man-made bone. Let me tell you what's really happening there. Picture this to be calcium carbonate, and I'm going to take the top layer of calcium carbonate out. Now, blessed as we are with that knowledge of the second lecture of the architecture of crystals, we now can, as it were, look inside a crystal and know where the atoms are. This is the calcium, here's the carbonate, these blue braided atoms at the bottom there. What this group in Pennsylvania has done by clever inorganic chemistry is the following. It's converted the original rock of calcium carbonate, coral, into calcium phosphate. Now, I've got calcium phosphate up here. If I were to take this off, if I were to tear it off, I'm going to do that, in a rather fierce fashion. Here it is, look. Now, that's sort of the chemical process that's happened. In the meantime, I've chipped off a phosphate molecule, but that doesn't matter. Now I've converted it. You know, that's a clever thing to do. It's like taking the Albert Hall, deciding to rebuild it, but not take it down. You take out every other brick and stuff in alternative bricks in their place. That's what this group in Pennsylvania has done. And it's a marvelous piece of progress because now the porosity of the coral is transferred to the porosity of the bone. Here is an actual piece of man-made bone in Pennsylvania, now under test in the United States. It's a major breakthrough, but still under clinical test. Now, how about gout then? And how about these other problems of crystal growth, which doesn't really occur when we expect it to occur? Well, I can explain that. See, I told you about the alum earlier. It's been growing steadily on a clean surface, uncontaminated, all over the past few days. No problem. Here's calcium phosphate. If it were clean, calcium phosphate can grow on top of it and on top of it and so forth. But if you have a little monolayer, just one thin layer of, shall we say, a carbohydrate or serum or whatever, it can stop now. This doesn't fit so readily now. It can stop. So the belief is that when you don't get crystal growth in the bladder, it's because those little crystals of calcium oxalate that are there are covered with an inhibiting agent generated by nature, which stops further growth. And in gout, although we know it's uric acid that's really the problem in gout, those people who suffer from gout generate a lot of uric acid. Incidentally, it correlates well with high IQ, so I'm told. If you've got a high intelligence quotient, you're likely to produce a lot of uric acid. Whether they're correlated strictly is another matter. But those people who suffer from gout may not have this layer, and consequently, it's easier to grow crystals on top of them. That's the explanation. Now, I mentioned earlier that we could remove kidney stones. Here's a patient, or this is an X-ray picture taken in London less than a month ago, before a particular patient had his kidney stone removed. Can you see that kidney stone? Here it is, very clearly there. Now, this person had that stone removed, and he was reading a book. He was perfectly conscious. He wasn't anesthetized. How did that happen? Here we are, you see. We can put up this picture. Stone is gone. An hour or so later. How did that happen? I'll tell you how it happened. You may remember this crystal of quartz that I took out in the first lecture, and piezoelectricity and Pierre Curie. All I want to tell you is that if you have piezoelectric crystals and you put a pulse of electricity, voltage pulses here, you'll generate a sort of pressure pulse here. So you can produce ultrasound. You have thousands of these. Put them all to work together and let the sound be focused on that stone, and it's eliminated. And that's a very major development which is now being used in the hospitals of Britain and elsewhere. Well, that's only one method of getting rid of stones. I'm going to now ask a friend of mine who is director of the National Medical Laser Center, Dr. Stephen Bound, to tell us more about eliminating stone. Tell us about the use of lasers.
Professor Thomas has described a very elegant way of destroying kidney stones up here in the kidney. But this technique has a problem. Those shock waves will not go through bone, and this part of the body, which is the pelvis, is fairly solid bone. Kidney stones have a habit of sliding down the urine passages and getting stuck there. And to get at those ones, we must look at another way of getting rid of them, and this is where lasers come in. Now, it is possible to approach the lower end of the urinary tract using instruments. It may give you horrors to look at this instrument and think that it's going in from below, but this can be slid in along natural passages and reach the area that these stones get stuck and cannot be treated by the shockwave technique. This X-ray is similar to the one that you've seen on the box there, and you will see this instrument is in place. It goes in at the bottom through the natural urine passages, up across the bladder, and can go beyond that to the place where these stones get stuck. Now, this instrument itself is just for looking, but with the aid of a laser, we can use it to treat the stone, break it up into small fragments, which will then be passed spontaneously in the urine. Now, this is the laser we use for this. It's a flash lamp pump dye laser. It has short pulses of just a couple of microseconds, and the beam is transmitted down an extremely thin fiber. And this fiber is just 1/5 of a millimeter in diameter. You'll see a red beam at the end. That's just the aiming beam to see where we're going. The actual treatment beam is green, as you will shortly see. Now, this is a very flexible fiber, and I'm going to pass it down the operating channel of this instrument. You see, this is very easy to pass. There we have the fiber at the end. Now, the beam is very bright, and normally one would have a filter on this, but for demonstration today, just to emphasize the power of this beam, I'm going to wear goggles. But don't look horrified in the front row. It won't be bright enough to cause you any trouble. So I'll just put those goggles on, and we will set the laser. And now we can fire at these stones. Now, it's very important that the fiber is kept in contact with the stone, and each crack you hear is each laser shot, and the stone cracks under that. You can see bits of stone now breaking away and moving away from the main bulk of the stone. And in a short time, one can get all the way through that. Well, that can be done without any incision in the patient. And I'm now going to show you a video of this happening in a real patient. This was a patient treated at the Institute of Urology in London, where this technique was developed. Here you will see this pink part is the normal tube that carries the urine. The brown part is the stone that is wedged in that channel. Now, this treatment has been partially carried out already, so the stone is already in largest fragments. And as the film runs, you will see the laser fired at it to break it up into very much smaller fragments. Each shot on the stone gives it a mechanical impulse, so it pushes it away as well as cracking it. So as the fragments get smaller, so they move in all directions, but eventually they're small enough to be passed out through the urine. So this patient needs only a day or two in hospital and can go home with no surgical wound to heal. There is the result afterwards. The urine tube is completely undamaged and the stone has disappeared. Thank you. Thank you very much.
Well, Dr. Bound will be appearing again a little later. Now, during the course of the past few minutes, you've seen a number of photographs of the skeletal outline of the backbone. Suppose there was some extra growth in the vertebrae, in the joints, as it were, not just of the backbone, but, say, of my knuckles. If that were to happen, they'd get inflamed. And on being inflamed, therefore, they'd be hot. Now, we can use crystals, liquid crystals, which are colored. You can develop, by clever chemistry, liquid crystals which are colored and change with temperature. The color changes with temperature. And my hand is resting on a pad here in the last few minutes or so. And when I take my hand away, watch what happens, see? Right? It's taken an imprint of my hand because it's measured the temperature difference. Now, I want a volunteer who's already pre-selected. It's Dion, is it? Come along, Dion. I want you to come and help me. Because we had to paint something on his hands beforehand. Or behindhand, whatever it should be, eh? Now, here we are. Look. Good, Dion. That's pretty spectacular. Now, I think you can easily see straight away that the temperature of his knuckles are different from the temperature of the back of the fingers. Are you prepared to put some heat on that, Dion? You tried it? Go on, put it on. See? There we are. It's not too hot for you, is it? Very good. Fine. Stop it now. Stop it now. Well, I think you can see. Thank you very much, Dion. That's very kind of you. Good. I think you can see that these liquid crystal paint, as they're called, are very helpful for measuring local temperature. There's another way in which we can do that. You remember in the third lecture, we had the thermal imaging camera, which could take photographs in the dark because it can take infrared radiation. Now, if I'm very hot in one part of my body, there'll be more heat going out, there'll be more radiation. You look at this normal knee taken in the Bath hospital, this. Here's a normal knee under the thermal imaging camera. Now we're going to switch shortly to an arthritic knee, you see, where there's problems, where there's inflammation at the knee, there's more blood and there's a higher temperature. So we can see that. Now that's the way in which we use crystals for diagnosis. But I don't want you to think that crystals in the human body are only largely related to what you might call the tough, inorganic, or unwanted crystals like bladder stones or bone. On the contrary, you know, even the soft parts of the body are crystalline to some extent. In fact, if I were to tell you that most of the creatures of creation are crystalline to some degree. If you look at the next slide, on this we have muscle magnified 900,000 times. The most obvious fact here is that these muscle fibers are beautifully ordered. There's periodicity. That is the nature of crystallinity. When that micrograph was taken in Cambridge about 30 years ago, it really enlarged our knowledge of muscles enormously, because it could help us explain, and the man who took the photograph built this model. It helps us explain muscle contraction. If I magnify the human muscle about 100 million times, it's going to look like this. There are two filaments, two sets of filaments, one rather narrower in diameter than the other. And what happens in muscle contraction is that they slide over one another. Bryson is going to switch it on. Thank you, Bryson. That's muscle contraction. Now, that's a rather tougher part of the body. Let's go to the really soft part of the body. Let's go to the living cell. Now, there are billions upon billions. Zoe must have countless billions of cells in her body, as every one of you has, as I have. Now, if I were to magnify one of those cells, which are barely visible under the microscope, to the size of this auditorium, then the little membrane that contains that cell, that keeps everything together, would just be barely visible. It'd be about 0.5 millimeter in thickness. If I were to magnify it another 20 times, it would have this thickness. And it would look like that, as a matter of fact. But what I want you to really see is the surface of that membrane is beautifully crystalline. It's lovely and ordered. Even the soft parts. And molecular traffic galore goes through there. The surface of a cell, as I've shown here, is an extremely important part of our lives. You know, it protects and contains this powerhouse, this engine room, where all the important work is being done to keep us alive. This, you know, you can almost use Shakespeare's dictum here, this fortress built by nature against infection, to protect herself against infection. It isn't quite true, actually, because when viruses strike the top surface, they're like savage marauders. They get through. They really do trouble. The trouble that you get is going to be illustrated shortly. You've heard, I'm sure, of all the various viruses, the polio virus, the AIDS virus. The AIDS virus was detected only in 1983 using electron microscopy. Let me show you an electron micrograph on the next slide. This was taken in America about 20 years ago. You might, if you were let your mind roam, you might think that that's an aerial view of an Aztec temple. It's really lovely and pretty. Some say that the Hanging Gardens of Babylon were like that. Well, the fact is, this is a million-fold magnification of a crystal of virus. There are hundreds of thousands of individual viruses there. And now, by the techniques I mentioned in the second lecture, we can determine the structure of each individual virus particle. And the amazing thing is, it's like a football. And I really mean that. It's like not the type of football I used to kick around when I was a teenager, but the modern football. It's because you have 6-membered and 5-membered regions all over the surface of these spherical viruses. The polio virus is like that. The human wart virus is like that. The tomato stunt virus is like that. Now, here's a model built in Cambridge by some of the world's leading authorities on viruses. And what I want to show you is, there and there you see 6-membered and 5-membered, just as we had in this modern football. Now, viruses are extremely important things. I don't have too much time to tell you all about them, but I want to do one thing before I hand over to Professor Phillips. I want to take you on a ride, on a helicopter ride, but it's a miniature helicopter, and we're going to make ourselves very, very small. We're going to fly over the surface at low altitude, over the surface of a virus. Here it is, look. We're going to go on this ride. Here we go. These are the virus particles, and we're going to roam over that surface. Look at the millions of them. Sometimes there are little defects. Sometimes there are some viruses missing. Sometimes they're not even crystalline. And sometimes they're very well ordered and crystalline. And on and on and on we could go. This is a magnification of something like 10 million that we're using here under this scanning electron microscope. And shortly, having roamed quite a distance, like these vironauts, not astronauts, we can say goodbye to that surface, and that's it. Now, viruses present us with many problems. Professor David Phillips is now going to tell us how we can overcome some of those problems. Professor Phillips.
Well, the medical profession is as much interested in how to destroy viruses as in their composition and their structure. And light can play a part here. Look at this baby's face. He is suffering from a herpes virus infection, and the treatment, which you will see in a minute, consists of painting a dye on just this half of his face and then irradiating with the appropriate colored light. It's called a photodynamic therapy, and the virus is killed, as we can see. Quite a considerable cleaning up on this side of the face. Both are necessary. You need light. There's no light, there's no cure. There's no dye, there's no cure. So it's a sensitized reaction. The branch of science which deals with that kind of treatment is called photomedicine. And of course, lasers have begun in the last 10 years to play an enormous role in photomedicine. But before we talk about that, I'd like to show you one further example of a phototherapy, a photo treatment, which does involve light, obviously, but does not involve lasers. Now, I need somebody to help me here, and I'm afraid I have pre-selected somebody for a reason which will become obvious. Rebecca, please will you come and assist? Now, she's going to play the role of Nurse Rebecca Searle today, so we have to put this expensive uniform on for her. And we actually need another volunteer, don't we, today? So I wonder if we can find one. Can we have another volunteer, please, Bryson? Ah, here he is. Now, isn't that nice? Now, Rebecca's going to help me take this infant from the cot. Off we go now. Can you go that side and just pull it across? That's it. You come across to the middle and help me. There we are. Now, the first thing we have to do is to get this rather voluminous nightshirt from him. Can you do that side and I'll do this side? And, oh, it's quite difficult, isn't it? Now, you notice I called in him for good reason. Now, what this baby has got is jaundice. In the first few days of life, many babies develop jaundice because of a yellow substance, which is a breakdown product of red blood cells and is normally excreted through the liver. But for some babies, that can't happen, and so this dissolves in fat. And we have a lot of fat just under our skins, and so you go yellow. We've simulated that condition here in this baby by having yellow legs. Now, just to show that he can't excrete it, we need to give him a drink. And Rebecca's now going to help me give him a drink. Very unusual baby, this. He drinks with a funnel through his nose. It doesn't complain too much and takes an enormous quantity of liquid all at once. I think that should be enough. Now then, whoops, remove the funnel. Now, as that water went in, a little of the yellow colour went into the water layer, but not much. Most of it is still in the fat. And so the baby still is suffering from this condition. And it can be very serious if the substance is allowed to build up. What we have to do to get rid of it is to irradiate him with blue light. This takes me a little time to do. There's enough blue light coming from this handheld ultraviolet lamp to give the therapy, and I'll start doing it. Now then, the reason I chose Rebecca, you've had an exciting event recently, haven't you, Rebecca? What happened?
My mum had a baby.
Your mum had a baby. How old is the baby now?
3 weeks.
3 weeks. And it's a girl or a boy?
Girl.
A girl? And what's she called?
Elizabeth.
Elizabeth. And what was special about Elizabeth when she came along?
She had jaundice.
She had jaundice. She had suffered exactly this condition. She doesn't suffer it now, does she? No, because she had this treatment. I think that probably will be enough radiation. So now we have to shake him up. Now, can you get hold of him with the other hand there? Get hold of his arm, his other arm, and we're going to shake him vigorously. All right, whoa, there we go. I hope you don't do this to Elizabeth. Now, with any luck, that will have been enough light to change this bilirubin, this yellow substance, slightly to make it dissolve in the water. And I think as it separates out now, you can see that that's true. So now he can do exactly what nature intended. Perhaps you could lift that receptacle up for me, could you? There we go. And now he can get rid of his bilirubin. Thank you very much indeed, Rebecca. Thank you. That might look silly, but that is exactly what you'll find in any maternity hospital. And with an audience this size, as many as 50, 60 of you will have had that treatment in the first few days of your lives. Well, lasers, of course, are of enormous importance in photomedicine. And powerful lasers can be used to seal tissue, they could be used to cut tissue, they could be used to remove tissue, or they could be used simply to kill living tissue. And what happens depends on what sort of laser you use and what part of the body you're dealing with. The first widespread use of lasers in medicine was to carry out operations on the eye. And lasers are used routinely on the eye to get over complications within the retina, the sensitive part of the eye at the back here, in diabetic patients. But some more recent treatments are perhaps more exciting. When you get old, the lens of the eye here can get cloudy, and so your vision gets very poor. The lens can be removed, but there's a membrane behind the lens there which can also go opaque, can go cloudy. And in order to get some vision, you have to remove that membrane. The way you can do it is to fire a pulsed high-powered laser at the membrane. Here you see the membrane in the eye, and there, if you look carefully, you can see a cross. A cut has been cut with the laser in the shape of a cross, and by making that cut, the membrane will peel back and restore some vision to this person. Now, we can actually see that happening for real in this little sequence. Here is the membrane, and when the laser fires, you see gradually a hole will be cut in that membrane. There we go. Watch the aiming spot. There is a hole developing and it gets wider and wider as the laser fires again and again. So this person has vision restored by having that kind of laser operation. In 20 years' time, none of us wear spectacles, because the focusing power of the eye is mainly concentrated in the cornea rather than the lens. And if you could reshape the cornea, then you can correct such defects in vision as short-sightedness, far-sightedness, astigmatism. A Russian scientist has pioneered a technique of cutting the cornea with a diamond knife, and this changes the shape, but you need 6 to 8 cuts through 90% of the cornea. So it's a somewhat hazardous operation. There is a danger that the eyeball will burst. Much easier, and this is being done on an experimental scale in London, if you take an excimer laser of the sort we've seen before and just take some tissue away from the cornea by firing the excimer laser at the cornea. What you really do is sculpt on the surface of the eye a contact lens, but in the living flesh. And it's a marvelous prospect for the future. We may not need spectacles in 20 years' time. Lasers, the laser which perhaps has been most used in medicine are of the infrared variety. And let me remind you that carbon dioxide laser is a very good cutting device. Here I have a piece of paper, and with a carbon dioxide laser I should be able to cut, if I'm very careful, a piece away. You can see that a nice hole has been cut in the, I'll get it right, there we go, in this piece of paper. So you can use a carbon dioxide laser for cutting tissue. It's used, for example, to treat cervical cancer in the early stages, but it has a disadvantage in that you can't steer carbon dioxide laser radiation down a flexible fiber. It can only go down a fixed fiber. I have shown you that lasers can be steered down a flexible fiber. Let me just remind you of that. Here is a little helium neon visible laser, which is being focused onto the end of a fiber there, and the light is traveling around this fiber, and I hope you should be able to see is emerging from here. Now, if you took a bundle of many flexible fibers, 10,000 for example, then you get 10,000 images, and so you can record a very, very clear image of something in an inaccessible part of the body. In the hands of an expert, you can see into inaccessible regions such as my pocket. Perhaps you could tell me about myself, Steve. What sort of things do I carry around in my pocket?
Well, you have some very interesting contents, David. There appear to be £2 coins there, which we can see on edge. There's a rather nebulous object which I suspect might have started life as a jelly baby. Yes, and there is a very friendly greeting that says hello.
Ah, well, you see what a friendly fellow I am. It actually says hello, Steve. But very good. Well, now this particular endoscope is a very superior one, latest technology. It has 100,000 equivalent fibers because it has a charge coupled device camera on the end of it. It has a little TV camera on the end and gives very, very high resolution indeed. Such endoscopes can be used not only to see into inaccessible places, but to carry out some rather delicate operations. And in order to show you this, we need Melanie Thody, my assistant, to come and show you something. Melanie is a lady with some bad habits, and we're going to try and cure her of one of them using this endoscope. Now, Dr. Bound would usually use this in a situation where he can't see. So just to simulate that, we need a screen between him and the patient. There we go. Now I need to assist without looking.
Right.
Okay.
Let me give you this. Fine. Now we're going to do this by remote control so that you will see but we're having a good look around to see what we can find. There we are. Now we have Melanie in view, and we will close in on that. Now you see that cigarette that I'm going to endeavour to remove from her mouth. Coming through the end of the endoscope, you will see a closed snare. And I'll now ask Professor Phillips to open the snare. There's the wire loop coming out. Now, could you advance the endoscope a little, please? That's fine. Now, we ask Professor Phillips to tighten the snare, tight as you can, and now we will be able to remove the cigarette from her mouth. Good.
Melanie, promise you must not smoke that cigarette, and thank you very much indeed.
Now this is a rather special endoscope. It's called a Christmas endoscope. You've seen how it works in the normal manner, in which we've been able to see things round corners, not always quite where we expected them to. But this particular one has an extra Christmas property. It has a nose. And you'll see its nose is twitching a little at the moment. I think it can detect something interesting. And if we look over there, I think we'll see Bryson with something that might stimulate our olfactory senses.
What Bryson has just brought on is a piece of recently cooked bacon, which you can compare in size with the size it started out to be. That illustrates an interesting point, that if you put infrared radiation onto protein, muscle, it contracts, it shrivels up. And that was widely used in the early days of using endoscopes and infrared lasers to seal bleeding tissue. But who better to talk about that than Steve Bound, who does this routinely.
Brilliant. Now, if you imagine the principle of cooking the piece of bacon on a very small scale, you can take a small area of tissue, and when it's heated in that way, it will contract and become firm, just like the bacon is when it's cooked. Now, this is the way we can stop bleeding from peptic ulcers. This is a picture looking inside the duodenum, that's just beyond the stomach, of a patient who had had a recent hemorrhage. This is the normal part of the duodenum. This black hole is the way forward down their intestine, about 22 feet to the open air. And here, the pale area is the ulcer. Now, you will see in the middle of that ulcer there is a red blob. That is the artery that has bled. And what we will do with the laser is to treat, like the bacon, around that vessel to stop it bleeding again. We now move on to a treatment of a patient very similar to this, who was actually bleeding from a duodenal ulcer when this film was taken. It's a little dark, but here we have fresh blood in the duodenum. You can see it welling out from the duodenum. And now, after a little preparation, we've identified the bleeding point down here in the ulcer. The laser shots, you'll see them being applied here around that artery to stop the hemorrhage. Only takes about 6 or 8 shots, but if they're in the right place, that patient will stop bleeding and they will be saved a major operation. Instead of spending a week or two getting over the operation, they can have a normal dinner just a few hours later. And there's the final result. Thank you. Now, that was the first application of lasers inside the human body down the flexible endoscopes. Most of our work now is concerned with treating tumors. Now, it is a sad fact of life that the majority of tumors, both of the intestinal tract, that is the gullet and the stomach, and of the lungs, are too far advanced to be able to cure them at the time they cause symptoms. This means that all that the doctor can do is try and relieve their symptoms by unblocking the bulk of tumor that's causing an obstruction. We're lucky this afternoon, we have a patient who's agreed to come along for a demonstration of this form of treatment. Patient's had a slightly bumpy ride in here, but nevertheless is feeling very sleepy now. Now, what we're going to do is to pass the endoscope through the mouth of this patient. He's very kind, he won't protest too much. And we're going to pass it into the back of the throat, and then we'll be able to look either down the gullet or down the lungs. But in this particular case, we're going to look inside the lungs. Our demonstration with the cigarette looks very nice, but it has a very serious purpose. Cigarettes kill because they cause lung tumors. We're going to demonstrate how you would treat an advanced tumor to stop it blocking the breathing. I cannot cure the patient, but I can make their last few months very much more comfortable. Right, now I'll ask Professor Phillips to hold the head. And you will see us going in the back of the throat. Now, on that side at the top, we're looking down into the lung, and that's the way we will go in a moment. But the other side, that will be going down the gullet, and we would go down there into the stomach. Now, we'll come back to the lungs, because that's our area of interest today. And while we're just going down there, I'll ask Professor Phillips to set up the laser. We're now past the larynx, and we're going down, that's the voice box, and we're going down into the airways at the top of the lungs. And here, getting down to where the airways split into the route forward into either lung, you'll see our simulation of a tumor. If you look very carefully at the top and the bottom, you can just see the airway going into each lung. Now, the endoscope is in position, ready for treatment. We just have to set up the laser to choose the right power and the right exposure time. We're going to give shots just of 1 second at 60 watts. There we are. Now, this is our fiber, quite similar to the one we used on the other demonstration, slightly larger in diameter, with a little gas around the outside just to cool the tip. Can you enable the laser, please? Now, much longer endoscope than the other one. We have a longer route. Now we see the laser fiber coming through. We'll turn up the light intensity a little. We'll move down closer to our simulated tumor, and we're ready to fire. Now, it's quite bright at the moment it fires, but you can see as we move closer, turn the light down a little bit, we are beginning to burn a hole through that tumor. Right, and now you can see there is a passage beginning to develop, and if we continued that treatment, we could remove the bulk of tumor there. But we'll stop treatment there, and we'll disable the laser, remove the fiber. Take the endoscope out, and I'm now going to show you a video of a real patient being treated for a lung cancer. This is a diagram of the situation we're dealing with. This is the airway coming down from the mouth and splitting into the airway to the right lung and the left lung. Here is the tumor. As you can see, it is blocking most of the trachea, and that patient has great difficulty breathing. Now, as I've said before, we cannot cure that tumor, but we can open up that blockage. And this is what you will see on the video. Here's the normal airway. Here's your laser fiber. There's the aiming spot. And this area, a little dark in this view, is the tumor. And as the treatment proceeds, you will see the tumor in that area being vaporized by the laser. 1 second shots just to vaporize tissue in the same way you saw it on the model. Here is the coagulated and vaporized tumor, and now we can slide past the tumor where it was previously blocked, and you can see the airways going forward into each lung. So now that patient will be able to breathe very much more comfortably.
Well, we thank Dr. Bound for his marvelous contribution, but we haven't finished with him yet, because for the final example of lasers in medicine, I'd like to describe some work which he and I and the Imperial Cancer Research Fund collaborate on. This is a way of targeting tumors by using dye stuffs, and it's very similar to the effect on the baby that we saw right at the beginning when I was speaking. Here are 2 dyes which, if injected into the bloodstream, will diffuse throughout the body, but in some places will stay longer in tumour tissue than in normal tissue. And so we can see that they're there because they have a very strong red fluorescence. Now, one such area of treatment is in the treatment of leukemia. If you look at the screen here, you'll see bone marrow in which the small red cells are normal blood cells, but the big cells that you can see now are leukemic cells, cancer cells. You'll see that it is mainly the leukemic cells which have the dye in them. If you shine light of the right wavelength now to be absorbed by that dye stuff, then you can destroy them, but you only destroy the tumour tissue. Well, we thought the easiest way to show you that was to have a model, and here it is. And I'd like somebody to help me. Yes, I think you had your hand up first. You can come on down. We can see, if you come around the back beside me here, you see that little red button? When I say fire, just push that red button, but not until I say fire, right? Now, there are the cells. This is the bone marrow that's been extracted. We've added the dye stuff and waited, and in subdued lighting, I think we ought to be able to see that just some of those cells fluoresce. The ones in the middle, in fact, I think, are fluorescing fairly strongly. They're the leukemic ones. They're the ones that have to be destroyed. All we have to do to destroy them is to turn on the light from, could be from a laser. So switch on now, please. There we go. And with any luck, we have destroyed the cells. Thank you very much. Thanks a lot. And the whole point of that is that it is only the tumour cells that have been destroyed. So that cleaned up bone marrow can now be re-injected into the patient, and with any luck he's cured. Well, we've almost come to the end of this lecture, and I know Professor Thomas wants to say a few more words, so over to him. John?
Well, in the course of these 6 lectures, we've shown you many things, some of practical, some of fundamental importance. One of the things that we showed you in an earlier lecture was this famous book, Micrographia, which was published 300 years ago by Robert Hooke, a brilliant fellow countryman. In his preface, Robert Hooke declares that it is the great prerogative of mankind to behold the works of nature. Not only to behold them, but to consider them, to compare them, to assist them, to alter them, and to improve them. Now that is the path from pure science to applied science. Well, I hope you enjoyed yourself. We want you to enjoy yourself even more, and to that end, I'm going to do something. Stand back and be prepared, and wait and see what happens.